Welcome to The Explainer. All right, let's just dive right into this. If you're a junior doctor navigating a busy ward, you already know that high-stakes moments can happen in the literal blink of an eye. Today, we're mastering an absolutely vital clinical protocol, the acute lower GI bleed algorithm. We're going to take what looks like a really complex web of medical decisions and transform it into a clear, straightforward survival guide that you can rely on when seconds count. Picture this. It's the classic adrenaline-pumping page literally every resident fears. You're on call, it's 2 a.m., and you hear those dreaded words from the nurse's station. Doctor, the patient in bed 4 has massive hematochezia. Suddenly, you're the one everyone is looking at to make the right call. The pressure is on, but with the right mental map in your head, you can handle this with absolute confidence. To keep us from hitting cognitive overload, we're breaking this battle plan down into 6 parts: the bloody ward call, the urgent checklist, the shock index toll booth, the unstable fast track, the stable local road, and finally, vital management rules. Okay, part 1, the bloody ward call. Let's look at the common suspects. Before we even start running the algorithm, we need to know exactly what we're dealing with when a patient actually presents with hematochezia. Look at this lineup of usual culprits. Notice the sheer variety of causes here. But check out what's right at the very top: diverticular bleeding. That is your most common adversary. Imagine an elderly patient with a sudden, completely painless rush of bright red blood. Diverticular disease should immediately jump to the forefront of your mind. But you've got to keep the others, like ischemic colitis or maybe a recent post-polypectomy bleed, right there in your peripheral vision depending on their history. Moving right along to part 2, the urgent checklist and initial resuscitation. When you actually reach the patient's bedside, making a clever diagnosis takes a temporary backseat to pure stabilization. Treat this exactly like a Formula One pit stop checklist. Before you even think about ordering fancy scans or waking up the on-call gastroenterologist, you must secure your patient. Step 1, ABC stabilization, airway, breathing, circulation. Step 2, establish 2 large-bore IV lines immediately. You need that vascular access secured before their veins collapse from volume loss. Step 3, draw blood for your standard panels: CBC, coagulation profile, liver and renal function, and whatever you do, absolutely do not forget the type and cross-match. You might need blood, and you're going to need it fast. Which brings us to part 3, the shock index toll booth. This is the crucial pivot point for us today. Calculating the shock index is incredibly simple, but it entirely dictates your next moves. You literally just take the patient's heart rate and divide it by their systolic blood pressure. If that number is greater than 1, your patient is hemodynamically unstable. Period. Think of this as a strict toll booth that routes your patient into one of 2 completely different clinical workflows. So this creates a hard fork in the road. On the left side, we have our unstable patients with a shock index greater than 1. On the right, our stable patients sitting at exactly 1 or below. You really cannot mix these up. Let's explore that unstable left side first. Welcome to part 4, the unstable fast track, for those with a shock index greater than 1. This is the high-speed expressway. For these unstable patients, delays are quite literally deadly. The workflow here is immediate resuscitation with IV crystalloids and targeted transfusions, immediately followed by an urgent CT angiography, or CTA. If the CTA is positive, you're moving straight to catheter angiography and embolization. If that doesn't control it, well, you're looking at surgery as a last resort. But listen up, because here is a massive red flag for junior doctors. Do not delay this process for bowel prep or a colonoscopy. Unstable patients need rapid imaging and bleeding control, not to be sitting in an endoscopy suite. I want to pause on this number for a second: 15. Because 10 to 15% of presumed severe lower GI bleeds are actually massive upper GI bleeds in disguise. Blood is a cathartic. That means a huge bleed up in the stomach can move so incredibly fast through the transit system that it looks exactly like a lower bleed by the time it presents as hematochezia. So if your unstable patient has a negative CTA, you must exclude an upper GI source. It happens more often than you'd think. Let's shift gears to part 5, the stable local road. This is for a shock index of 1 or less. If your patient at the toll booth was stable, we downshift the pace of it. We're off the expressway, but we still need to calculate their risk methodically. This is where we build our risk assessment using the Oakland score. This tool uses really standard variables like age, sex, vitals, and history to give us a hard, objective number. For example, let's say you're evaluating a 72-year-old guy. Okay, that's 2 points for age, 1 for male sex. He actually has a history of a previous lower GI bleed, so we add 1 more point. His heart rate is okay, but he passed out, had syncope earlier in the day, which adds another 2 points. Just from chatting with him and glancing at his chart, we're already at a score of 6. Once you tally those points up, you just look at this super simple cutoff roll. An Oakland score of 8 or less means it's a minor bleed. You can actually safely discharge this patient for an urgent outpatient evaluation. How great is that? But a score strictly greater than 8 classifies it as a major bleed, meaning you absolutely must admit them for inpatient management. This totally takes the guesswork out of patient disposition on the ward. For the patients who are admitted to the stable local road, here's what their journey looks like. First, they need heavy bowel preparation. We're talking 4 to 6 liters of PEG solution. Why so much? Because within 24 hours, they need a colonoscopy. And adequate prep is totally essential so the endoscopist can actually see the source of the bleeding and apply endoscopic therapy, whether they're using clips, thermocoagulation, or an epinephrine injection. Finally, we reach part 6, vital management rules. Regardless of whether your patient took the fast track or the local road, these are the universal rules of the road that apply to everyone. First up is our transfusion strategy. And the rule here? Restrictive. If the patient has no cardiovascular disease, you only transfuse if their hemoglobin drops to 7 or below, aiming for a target of 7 to 9. Now, if they do have significant cardiovascular disease, your threshold bumps up to 8, targeting 10 or above. Less is often more here, guys. Pumping a patient full of blood unnecessarily can actually increase bleeding and mortality. Next is antithrombotic management. Honestly, this is a total minefield for junior doctors. If they're on DOACs, temporarily withhold them. If they're on warfarin, interrupt it right at presentation, and absolutely use reversal agents if it's life-threatening. But look at this last point very carefully. Do not routinely stop dual antiplatelet therapy or DAPT for patients with coronary stents. You have to balance the bleeding risk against the very real, terrifying risk of them having a fatal heart attack right there on your watch. Liaise with cardiology immediately on those ones. I want to show you one more really critical number. Think about this. Overall, in-hospital mortality for lower GI bleeds is usually about 3.4%, but that mortality rockets up to 20% if the patient requires 4 or more units of transfused red blood cells. Remember what we just said about the restrictive transfusion strategy? Yeah, this is exactly why. Mortality relates highly to the patient's comorbidities, not just the exsanguination itself. Okay, let's wrap this up by summarizing the key clinical pearls to keep your patients safe. I'll say it again because it's that important. Do not send unstable patients to colonoscopy before getting a CT angiogram. CTA is rapid, it's highly accurate, and it perfectly guides your radiologic therapy. Avoid a blind segmental colectomy at all costs. Surgery is an absolute last resort, reserved only for when endoscopic and radiologic therapies have failed and there is a massive transfusion requirement. Which brings us to our final thought for this explainer. The goal of this entire algorithm is to identify the bleeding source and fix it as non-invasively as possible. Since surgery is the absolute last resort, you have to ask yourself, are your early imaging and resuscitation steps robust enough to actually save your next patient from the operating table? Master this checklist, respect that shock index toll booth, and you're going to be fully ready for your next ward call. Thanks for joining me on The Explainer, and keep learning.